I now invite Dr. MRUTYUNJAY Bilagi to talk about lessons learned in managing laryngomalacia. Dr. Bilagi is one of the earliest movers into pediatric airway in the country. He's had over 20 years' experience in the field. Over to you, sir.
Krishna, you made my life comfortable. No, Balakrishnan. Oh,
Hello, sir. Can you hear me?
Balakrishnan, can you hear me?
Yes, I can hear you, sir. Namaskar.
Many thanks. You made my life comfortable. Unlike you, I envy you. You're working in a wonderful center. I'm a lone ranger. I'm fighting my single war. There's one soldier war for the last 20 years, managing these cases. And this is what I learned my way. I need, if there is something I do wrong or you can improve my technique and all, so that I can do more for my troubled souls.
Not at all. I look forward to learning from you.
Yeah, I bring you greetings from Aurangabad. It's a historic city, famous for World Heritage Site, Ajanta Ellora. Laryngomalacia is a apt term coined by Jackson. I can't see that. In 1942, for a very appropriate term for a flaccid larynx with supraglottic tissue collapse into the laryngeal inlet during inspiration, causing partial obstruction, leading to flutter, giving rise to pathognomic stridor of laryngomalacia. As you know, complex organogenesis of airway is cause for many congenital conditions affecting the airway. Other than congenital conditions, I cannot. It is affected by traumatic, infective, neoplastic conditions. And whatever may be the condition affecting the airway, the symptoms are very non-specific. These are stridor, hoarseness, and feeding difficulty. It is the onus of the attending clinician to come to definite diagnosis before he embarks on therapeutic interventional plan. And what really helps me, this wonderful tool, thanks to Professor Shigeto Ikeda, who invented this. Prior to endoscopy, there is no diagnosis, only impression. You all know this quote. And to illustrate what can go wrong if you try to treat this patient on your inferential diagnosis or presumptive diagnosis. This is an 11-month-old child managed in a tertiary care center for stridor since birth. As a case of laryngomalacia, patient had 3 episodes of respiratory arrest, and they invited me to diagnose the case. And when I put the scope, larynx was absolutely normal. The trachea was compressed by a superior mediastinal mass. And me and my thoracic surgeon friend decided to operate upon. Unfortunately, this child succumbed to a severe bout of hemoptysis evening before we planned. And Aurangabad is a tertiary center for neonatal care. Almost 200 beds are dedicated to neonatal care. Every child of stridor gets referred to me, but with a referral note of a case of stridor for evaluation. There is nothing wrong on part of my neonatal friends to think laryngomalacia is the cause of stridor. Yes, it is the commonest condition affecting the airway, but I feel there is a bit of overdiagnosis the way the children are examined. And even I did the same when I had no flexible scope. That beautiful collapse you see of supraglottis, and the same child investigated transnasally, scope transnasally, absolutely normal larynx. So for proper evaluation and precise diagnosis, one has no alternative not to have transnasal flexible scope and the expertise to use it. That doesn't mean that history and physical examination is superfluous. No, a properly done job will definitely help, will provide a definite pointer towards a probable diagnosis. And then I subject my patient to awake transnasal bronchoscopy. With this approach, other ancillary investigations are not needed. The commonest condition I am seeing in my cases are laryngomalacia, as it is obvious here. Other conditions I am seeing is vocal cord palsy, subglottic stenosis, clefts, complete tracheal ring stenosis, various cysts like base tongue cyst, epiglottic, retropharyngeal, paratracheal, laryngocele, and so forth. Yes, as you said, as you heard, It is the most common congenital condition affecting the airway. And male are more prominently affected, and cause is unknown. That explains many theories in its etiopathogenesis. As you heard Dr. Balakrishnan, it is the inspirator stridor, which doesn't appear at birth, but it appears later date. It's worse when the child is agitated, associated with respiratory obstruction and all, feeding difficulty leading to failure to thrive. I like to classify laryngomalacia as type 1, type 2, type 3, depending on the collapse of anterior collapse of the arytenoid, lateral collapse of the larynx, like type 2, and in type 3 it is and posterior collapse of epiglottis. And there is one interesting phenomena I observed with the laryngomalacia, is it is associated with subglottic stenosis, vocal cord palsy, base tongue cyst, unilateral coronal atresias, cleft palate, tracheomalacia, pyloric stenosis, esophageal atresias. A good number of them had deviated nasal septum, and most of them had laryngopharyngeal reflux associated. All textbooks and literature says what about laryngomalacia? Laryngopharyngeal reflux is an associated condition with laryngomalacia, but I feel it is not an association. It is the result of increased inspiratory effort the children have, causing greater intrathoracic negativity, allowing easier opening of cricopharynx and cardiac sphincter, allowing flooding of gastric content into nasopharynx and laryngopharynx, causing adenoidal hypertrophy and supraglottic edema, adding further to the already existing inspiratory burden. One such example, this 16-day-old child was comfortably sitting in the lap. The moment it is put on its back, child becomes very stridulous, and when I scoped the child had a base tongue cyst which was pressing onto the larynx, epiglottis. Here I was not sure whether there is a concurrent existence of laryngomalacia along with the cyst. It will be evident only once I take care of the first. You heard this, Balakrishnan, it's a self-limited condition, but I want to say that regular follow-up is very essential. 15 to 20% of my patients present with aggravated medical symptom aggravation, and they require surgical intervention later date. So what is my role in managing these cases? Yes, I am the one who decides which particular patient requires surgical intervention. Stridor being is the stridor, its loudness is the criteria for decision? No. A type of laryngomalacia, it has no link to the morbidity these children will have. This is an example of to illustrate the laryngomalacia, the type, and has no link to the morbidity these children suffer. This is severe distress and severe reflux, and the type 1 laryngomalacia. I operated, child is fine. So I take into consideration the flexible scopic finding of extent of laryngeal collapse and sequelae of respiratory obstruction and feeding difficulties the children have. And when I decide to operate, transoral approach is the preferred way to tackle this. And my surgical options available with me are supraglottoplasty, epiglottopexy, and of late I started doing partial epiglotectomy, suprahyoid, and I do take consent for tracheostomy in each and every patient. As you heard that tissue orgated in epiglottopexy, we create a raw area in the adjacent base tongue and epiglottis and put a stitch. As I said, partial epiglotectomy is the newer option available with me, and in the beginning I had fear in my mind whether these children will have post-operative feeding difficulty, but that fear disappeared when I encountered this child. This is a type 1 laryngomalacia case with severe distress and feeding difficulty, and when I went inside, type 1 laryngomalacia, but I will notice one thing, it had a congenitally truncated epiglottis, and I went ahead with my plan, and fortunately there was no post-operative feeding difficulty. So I became bold and I started doing partial epiglottictomy in my patients. So far, the commonest procedure I'm doing is proglottoplasty, epiglottopex few, and partial epiglottictomy 2 cases. And as I said, tracheostomy, I take consent for all my patients, but none I had to work. I encountered 2 deaths. One was, it was a syndromal child. Other one, I operate the child and patient goes back to the neonatologist. He reached the place, but they found him dead in the recovery room and all. There was recurrence of stridor. I usually call my patient, but they are from far off places, and they refused. They did not come. I thought, I scoped the child, and most of them were adrenal hypertrophy. They failed to take anti-reflex measures, which I advised them, and I advised them to come to me again and again. They couldn't, because they are poor people and they are very far off people, places from my place of work. Few illustrative cases. A 3-month-old child with breathing and feeding difficulty, and there is no noise, the sound here. And this was severe reflux and type 3 laryngomalacia. Operated, this is 6 months. Now the child is 5-month-old, 9-month-old, and there's reflex has gone. This is what happens to my supraglottic larynx, and child has gained weight. This is 6-week-old child with breathing and feeding difficulty, base tongue cyst. As I said, I was not sure about associated laryngomalacia with this patient, and then when I operated this child, I could send without second surgery, because as it was just a mass effect of the base tongue, which was pushing onto the epiglottis and causing added obstruction. As I said, when the second pathology at 2 different levels, it's easy to diagnose, but this particular case I had tough time. This is a 2-month-old child with webbing of neck, repeated aspiration, pneumonitis, and what this child had, cleft palate and cleft larynx. You can see the glottis closure. This is the cleft. I had to do tracheostomy because of webbing I was not able to put him into proper get the proper exposure. I did tracheostomy. I repaired the cleft, and I wanted to decannulate. I failed to. Then when I went in again, and I saw the moment I repaired the cleft, the laryngomalacia became evident. So I had to do partial epiglottictomy in this particular case, and he is now 2-year-old. That's the repaired cleft, and that's the truncated larynx. It works well, and these people do not have any feeding difficulty post-operatively. So other than laryngomalacia, I am doing various cysts. I am marsupializing them. Bilateral abductor palsy, my preferred technique is posterior chordotomy. Subglottic webs, I radially cut them with balloon dilatation. Laryngeal cleft, I repair in layers. Congenital ring stenosis, I expand them, and papillomas, atrezias, and so forth. Every child with stridor need to be investigated on emergent basis. Unattended, unrelieved obstruction can have chronic morbidity or mortality. All stridors are not laryngomalacia. Correct diagnosis is must for favorable outcome. There is no alternative for transnasal bronchoscopy in management. There can be concurrent condition needs to be looked for and addressed. Laryngopharyngeal reflux is not a concurrent condition, needs to be managed effectively. And as a ENT surgeon, I have a role in decision making. Even in mild cases, I call them for regular follow-up, and also in operated cases. What I mean by this is, this child was operated 3 months back, child was fine. Even then they come for follow-up, and I usually follow up study. I nebulize the child. The moment I nebulize the child, the stridor became evident. What I mean is, the laryngomalacia economy has 2 components. There is one anatomic component and there is a neuromotor component. And with surgery, we correct the anatomic component. The neuromotor component still haunts the child, and severe bout of infection, respiratory tract infection, exertion, can precipitate stridor in distress. You saw that there was reappearance of stridor following that. So regular follow-up is very essential, and indicated cases transfer approach is the preferred way to tackle them surgically, and it's a team effort. I'm not alone. Along with anesthesiologist, pediatrician, thoracic surgeon, and pediatric surgeon, we join hand and give better life to my patients. I want to end my talk with this. I spread happiness to me and my patients around me. This child was operated when he was 2 months old for type 3 laryngomalacia. She is 3-year-old, and they keep coming. They're convinced about my role in, are they visiting me? That's what. She's 3-year-old, and I'm happy. Thank you.
Thank you, Dr. Bilagi. It's a very inspiring body of work that you have created over these years in Aurangabad by yourself.